All right. Good afternoon, everyone. Welcome back to our final presentation of the day. It's been a great day, busy day. So we are almost there. So this next presentation is going to be on skin integrity and the challenges with this population. This is a very important topic that we see across the age band with the different types of individuals that we take care of. So our two presenters today are Nicole Rogers. Nicole Rogers has been in the medical field since 1993. She came to the Center for Disabilities in 2014, where she oversees the long-term care facility, St. Margaret's Center. Here, she's the head of the wound care team and has developed policies and procedures as well as effective wound care protocols to help prevent and treat wounds at St. Margaret's. Diankah Eligon is a physical therapist with 15 years of clinical practice. She has extensive experience in wound care management and the use of adaptive equipment for people with physical and intellectual disabilities. Diankah is the current director of Rehabilitation and Article 16 Services for Constructive Partnerships Unlimited. She is responsible for the speech therapy, occupational therapy, and physical therapy staff throughout New York City and the Hudson Valley. She's also a clinical director for the Special Olympics Healthy Athletes Fun Fitness Program. Welcome, Nicole and Diankah.
Hi, Vincent. Well, as he said, I am the head of the wound team for St. Margaret's Center. We serve a population, we're a long-term care facility. Most of our clients, it's geared towards pediatrics. However, our clients range from the age of 1 all the way up to our oldest is 48. And we have 2 specialty ventilator units that are designed for pediatrics. Pressure ulcers are always an issue when it comes to long-term care. And in the 8 years that I've been with St. Margaret's, I've learned, because my background was geriatrics prior to that, I have learned that the pediatric challenge is a lot different than the geriatric one. And what I'm going to show you today is just a quick overview of what pressure ulcers are and some treatments that can be applied. And in what we've shared, there is what we put together, which is called the pressure ulcer guidelines that we use in our facilities to help the nurses and the CNAs identify wounds and to help pick the correct treatment. So as a nurse, the reason why we say that we are not moving, for some reason, oh, there it goes. We're the experts because we're the ones that have to apply the dressings. That does not mean that a nurse out of school is the expert on wounds. However, once you get to apply them, you get to learn them sometimes better than the manufacturers that make them. To start, I wanted to give a little overview of what skin is. Not that we don't know what it is, but it is some of the key points of skin is it's the largest organ of the body, multi-layered. Healthy skin should be soft, flexible, moist, and slightly acidic. Some key points to know with pressure ulcers, the thickest parts of the skin are found on the palms and the soles of the feet, and the thinnest is found in the trunk. The reason why that's key is because a lot of our kids or residents do have specialty devices, AFOs, things like that, and they tend to go on the softest parts such as Foley jackets. Some of the functions of the skin is they protect the inner organs. They help you with regulating thermal regulation. They prevent you from getting fluid loss. They help you soak up that sun and get the vitamin D. It allows you to excrete your waste when you're sweating. And obviously it provides a unique identity to an individual. As you can see, my skin is very pale, but there are other individuals whose skin go from darker to even lighter than mine. This is just a picture of what the structure of the skin looks like. This is helpful when you're looking at pressure ulcers because pressure ulcers are normally identified as stages. And depending on where in the skin level the pressure ulcer goes to is what stage you are at. As I said, there's 3 structures of the skin, the epidermis, the dermis, and then the hypodermis. And again, depending on how deep the actual ulcer goes or injury is what stage it is at. So what is a pressure ulcer? It's a localized injury to the skin or underlying tissue, usually over a bony prominence, but does not always have to be over a bony prominence. But it's usually a result of some sort of pressure or pressure with a combination of shearing, Shearing is when there's strain in the structure of the skin, like when you're pulling somebody up in bed and the skin goes, but the rest of the body does not go. When talking about bony prominences, this is usually where you find some sort of pressure points, which have on this picture here, you'll see there's different pressure points depending on how the person is laying. And this is beneficial to know because that's how you can identify a pressure ulcer possibly related to something not pressure. Some of the things that we as clinicians can do to help prevent pressure ulcers in the residents are we can turn a position. In our facility, we utilize care plans, what are called CARDEXs, which are how we tell our CNAs to provide care to our residents. Also provide prompt incontinent care because incontinence, urine, and feces play a big role in breaking down the skin. Proper detection is when we do skin assessments, looking at the patient from head to toe to make sure that there's no anomalies, anything off that doesn't look their usual. We must provide them with proper nutrition. And anytime you ever find any type of skin finding, something that's out of the ordinary, you always want to, for us, they notify us, the wound team, and the doctor. There are devices that we can use as well, which Diankah will talk more about to help relieve pressure from certain areas when it's difficult to relieve pressure. So if we get into pressure ulcer staging, a stage 1 is, for the most part, it's intact skin, and this is what a stage 1 looks like. It's red and does what's called a blanching or non-blanchable, and that's usually what we ask when it comes to pressure, because that goes to show whether it's just irritation from some pressure that can be removed once that pressure is removed versus an actual pressure ulcer. And how you do that is usually put pressure on the skin, the reddened area with your finger, and usually it turns white. If it turns white, that means that there has been no cell breakdown of the skin, so that all you should have to do is just relieve whatever is providing the pressure to that heel, and that redness should go away usually in 20 to 30 minutes. Now, if you press on it and it remains red and there's no blanching or whiteness that comes to the skin, then more likely there already is some cell death to the skin, and that means you have to have a little more action than just relieving the pressure. As I talked about blanchable versus non-blanchable, this is just a guide as to how you know it's blanchable versus not blanchable. As you can see from the blanchable section, the redness is pretty superficial, just on the top layers of the skin, where the other picture that says non-blanchable, that is a little bit deeper, and that means there is cell death that is occurring underneath the surface. The next stage is a stage 2. It is a partial thickness of skin loss that involves more than one the top layers of skin. It involves usually the epidermis, dermis, or it can be both. It's usually pretty superficial and sometimes appears as just a water-filled blister or a very shallow crater. This is a demonstration of a stage 2. It is a pretty impactful stage 2 that is created not only from pressure, but also from moisture, because you can see by the part of the body that that is where the incontinence would sit, causing the breakdown. Stage 3, now you're going into deeper layers. It's a full thickness tissue loss. There may be some fat visible, but you will not see bone, tendon, or muscle, and that's how you know stage 3. This may also include what are called undermining and tunneling, which I will show you in future slides. And the depth can vary depending on where it is, because obviously if it is in the forehead, there's not a lot of tissue or fat there. So it could be a stage 3 a lot easier than it would be, say, on the abdomen where there's a lot of adipose tissue. As you hear me talk through this, you'll see there's different wording of pressure ulcer versus pressure injury. For long-term care, we follow NPOP guidelines, and they have recently changed the common knowledge of pressure ulcers. They now like to call them pressure injuries, but they are both interchangeable words. So this is a stage 3. As you can see, it looks a little deeper. You can tell there's a little bit more depth to the wound itself. And in the middle here, you can see the yellow, which is, this is where you're going to see the fat, and that's how you know it's a stage 3. Stage 4, obviously the higher we get with the staging, the deeper the wound is. This one is a full thickness tissue loss with some bone or tendon or muscle exposed. It also includes undermining and tunneling. The depth can vary again, depending on where the anatomical location is. And usually you can either see the bone or feel it when if you touch in the wound with a sterile Q-tip. This is a stage 4 pressure ulcer. And as you can see, it's even deeper than the previous picture. And the white that you see in here, this is some tendon. And if you palpate it with a Q-tip over in the corner here, you would see that there's some bone that you can feel, which obviously you can tell it's bone because of the hardness. As I talked about in the last 2 stages, tunneling and undermining, which is very difficult for people to understand sometimes. So tunneling is where a canal is formed inside the wound, and it can either lead to nowhere, just go deeper as you see in that top picture, or there could be a second wound that it is tunneling to, creating almost like a fistula between the two. The second is undermining. Undermining is where it kind of goes under the skin, but the skin is still, or appears good on top. The problem with both of these is obviously it'll interfere with wound healing and treatment application. And also with undermining, you will measure, at the end when I show you how to measure a wound, eventually that wound will look bigger because eventually that top layer of skin will wear away and it now will be part of the greater wound. One of some other type of wound, skin injuries, pressure injuries, one of the worst kinds, because you never know what's underneath it, is called a deep tissue injury. It is a purple or maroon colored area. It can sometimes be a blister, but a lot of times it's not. It's just discolored, and a lot of people mistake it for a bruise. A lot of times you can tell what it is because it's painful. It can be painful. It's sometimes going to be firm, mushy, or boggy, and it usually is a warmer or cooler than the rest of the body. And it may be harder to detect in darker pigmented skin, being that it is darker, but a lot of times in darker pigmented skin, the skin turns lighter. This is a perfect example of a deep tissue injury. And like I said, the bigger problem with this is you never quite know what the damage is to the stuff below the actual surface. Unstageable. The reason why a wound is unstageable is because you can't see what's underneath it, whether it be because a doctor has ordered a device that has to stay, like a Uno boot or something like that, that's to stay and you can't assess the wound, or you can actually see the wound because it is a full thickness tissue loss, but the base of the ulcer is covered by slough, which is pretty much dying skin. It can be yellow, tan, gray, green, or brown. And you can also have some eschar in there, because if the eschar is there, which is like almost more leathery type slough, then you can't see what's underneath to really know how deep that wound is or what the structures are underneath. And until that slough or eschar is removed and you can expose the wound bed, it's very difficult to understand what is actually going on in that wound. One thing about eschar though is sometimes it's stable. A lot of times you'll find, especially with older people, they have like this dark black scab on their heel. That is eschar, but with that, what I was always taught is it's almost like nature's Band-Aid, and you really don't want to do much with that. You want to let it just sit there and keep it as intact as you can, because hopefully once the body starts to heal itself, that dark eschar will remove and good skin will be underneath. So this is an example of an unstageable. The reason why it's unstageable is because it's so full of that slough material that you cannot tell what is at the base of that wound. So you're going to want to remove all of that yellow stuff, which will take some time. And that way you can start treating it and get it to fill in and heal. Now, with those varying stages, there are other type of pressure ulcers. There are certain ulcers that can occur in the dying process that are called kidney terminal ulcers. They kind of look like a deep tissue injury. However, they're larger, and they're usually, depending on how the patient is lying, will result in the coccyx area because of the fact that that is where the blood pools. Those, unfortunately, because they are usually in a terminal patient, you really aren't going to do much with treatment for those, but you are going to try to make them comfortable. Now, in my world in long-term care, assessment of the wound is very important for documentation purposes, but also for treatment purposes and communicating to other parts of the team what that wound looks like. Because what we do is with our wound team, we evaluate the wounds once a week and determine if they're getting better or if they're getting worse, or if there's anything else that we may have to do, and then go week to week from there and communicate with the doctors based on what we've seen. Because unfortunately, the doctors cannot be there all the time. So they're depending on us to be able to describe what they see so they know what the progression is with the patient. So for wound assessment, what needs to be included, you must include what the wound bed looks like, what around the wound looks like, or the peri-wound tissue, how much drainage is there, if there's a smell or odor, what the temperature is, and what the size is, and if there's any undermining or tunneling present, and where it's located. The wound bed, again, you want to describe what it looks like. It's critical in the documentation process. Though I would love to have nurses stage a wound and say something is a stage 2, the more important information is what does that look like? So a lot of times I'll tell the nurses if they're not comfortable with staging, what they can do is just describe what the wound bed looks like, because it gives us that know wounds a little bit more in depth, a good picture of what the wound is at the time when they're looking at it. Part of that process with looking at the wound bed is saying what the color of the wound bed is. A healthy wound bed is always red in color. There's other descriptors that you can use when you're talking about the wound bed. Like I said, red indicates healthy tissue. The goal of treatment is to get the wound bed to stay moist and red, and the wound should mimic the moisture like the inside of our mouth. There is yellow, which indicates the presence of slough, which is moist, yellow, stringy tissue, necrotic tissue or infection. The goal of treatment is to control the infection if present and eliminate slough or necrotic tissue by debriding. And there are multiple ways to debride, which I'll talk about later. Black indicates the presence of eschar. It's dehydrated dead tissue. This tissue should be removed if possible and as a resident status allows. But as I told you earlier, unless you're looking at a heel wound with necrotic tissue on it. In my setting in New York State, all measurements must be completed by an RN because it is a form of an assessment. When measuring the actual wound, you must include the length or the longest part of the wound, the width, which is the widest part of the wound, and the depth, the deepest part of the wound bed. It's usually completed by using a cotton applicator or a sterile Q-tip. That's how we do it. And we have standard plastic individual measures that we use to do this. And each wound gets its own measure or its own Q-tip. When you're measuring, you always want to look at the wound like it's a clock and the resident is a clock. So the our head is 12 o'clock, our feet are 6 o'clock, towards my left arm would be 3 o'clock, and right would be 9 o'clock. Therefore, if we are looking at a wound that was straight up and anatomically correct with the body, the length of the wound would be 12 o'clock to 6 o'clock, and the width would be 3 o'clock to 9 o'clock, which sometimes can be tricky based on where the wound is located. Depth, like I said, is inserted is by taking a sterile cotton tip applicator into the deepest part of the wound and then taking that and measuring where that ends. Tunneling and undermining is always documented in centimeters and o'clock numbers. So if you're looking at a wound and there was a tunnel in there, you are going to describe it as undermining from 2 o'clock to 6 o'clock at a 3 centimeter depth. With that, you're also looking when you're assessing a wound to see if there's an infection. All chronic wounds have some sort of bacteria in them. It's called a bioburden. Our goal is to try to keep that bioburden to a minimum, if none at all. And what I always learned, an acronym to learn the signs of infection, is IFFY. Is there induration? Is there fever or warmth to the wound? Is there arrhythmia or toughness to the wound? And is there some edema? So when you're documenting this wound, what you want to include in your documentation would be the location, the shape, the size, the stage if able, tunneling and undermining if present, and the location, and the amount of exudate or drainage, and also what the peri wound looks like. The next is to choose the right dressing. You want to select a wound dressing based on the ability to keep the wound bed moist, because that's how it's going to heal. The need, if need, to address bacterial risk, meaning, is it an area where there's going to be a lot of urine or feces in that wound? Is it where you sweat a lot and there's more chance of bacteria to get into that wound? The nature and volume of the wound exudate, is it thick? Is it thin? Is it purulent? Is it just serosanguous? That's what you want to look at. The condition of the tissue in the ulcer bed, is it good granulation tissue, or is it mainly covered with slough? Because again, you want to get rid of that slough to get to the granulation to get the wound to heal. And then again, the ulcer size, depth, and location, whether there's tunneling or undermining, and how you're going to protect that area around the wound when it is draining. Some of the most common treatments that are out there that are used are gauze, impregnated gauze, a semi-permeable film dressing, meaning air can come through it, a small amount, semi-permeable foam dressings, which have a little bit more thickness to them, hydrocolloidals, and hydrogels. Those are just some of them. Now, based on how you want to choose the correct dressing is all based on what you think is going to work best with the resident. Honestly, for the most part, picking the right dressing sometimes is a, I guess you would say, a trial by error, because what works for one person and one wound may not work for the next. So you just have to keep that in mind. So gauze. Gauze is one of the most common dressings out there, but as you'll see, there's some advantages and disadvantages for all the different types of treatments out there, and what you can use. I'm not going to go through all of them because I'm hoping to get through this quick, because I do have some products that I'd like to show you on camera. I don't know if they're going to come through very good, but I'd like to show you. So these are the common types of treatments out there. Again, it's just, there are so many out there. There's a plethora. What we decided, because when I walked into St. Margaret's, there was a large quantity of almost every type of treatment out there that we could use, which is great. But on one hand, but on the other hand, it doesn't allow the nurses and the staff to learn the treatments when you're using a whole different amount. So what I did is I got together with one of our usual vendors and we created our wound care guidelines, which are in the handout part of the seminar. Now, besides dressings, there's also, when you have that slough in there, you have to do what's called debriding and trying to get to that good granulation tissue. There are 4 types. The first is sharp, and that's usually done with a scalpel to remove the necrotic tissue or the slough. And that is normally only completed by an MD or a qualified professional. Yes, a nurse is allowed to do it, but she has to have special training in order to do that. Then you have mechanical. You can do that with scissors, tweezers, or for us nurses, we do it a lot of times when we're cleaning out a wound, because we're using gauze to dry the wound or get rid of the whatever we cleaned it out with. And that does do a form of mechanical debridement. There is enzymatic debridement. Enzymatic is a cream that goes inside of the wound that uses stomach enzymes that are specially formulated in a lab to eat the dead tissue. The bad part about these type of things, these type of treatments sometimes is they don't really they don't tell the difference between good skin and bad skin. So sometimes they can affect the good tissue as well. And one of the main which I'm not endorsing any products, is Santal collagenase, but we've all used them, I'm sure, at one point in our nursing career for us nurses. And then there's autolytic. It's done by using the body's own skin enzymes that are already in the wound to actually get rid of the slough or necrosis in the wound. A lot of times treatments that we use on that, when we go to remove those treatments and put a new one in, that's what we're doing. We're using autolytic treatment. The other thing you have to keep an eye on, a lot of nurses misconstrue, is healing versus infection. And the reason why is because there's 3 phases for wound healing. And the first one is inflammation. It's where that redness shows up and everyone says, oh my goodness, it's going to be infection. But remember, every 1 to 10 days after the wound is created, it has some redness or inflammation. There is some cardinal signs for it where there is some heat. So it would kind of mimic infection. However, when the inflammation is occurring, sometimes it's very continuous, and you don't want that to happen because that can also slow the healing process. Proliferation, it occurs usually day 3 to 20 after a wound is created, and that's when granulation starts to come, which is that good tissue, which is what you want. And the remodeling can occur anywhere from 9 days onward, and that's where the tissue is starting to regenerate and wound has closed, and now you have a scar forming. The problem with pressure ulcers is once somebody has a pressure ulcer, the skin, what grows back in there is now what was there before. It's not the same structure. Collagenase replaces that. So that's why that skin is always more fragile and will never be the same as when you originally, before you had the pressure ulcer. So I'm going to stop sharing my screen and get on the screen for a minute. I can get it to expand here. Hold on one second. Oh, well, I was going to. Oops.
Let me know when to start, Nicole.
Yeah, I'm trying to get out of mine. Well, I was going to show you some treatments. One treatment I want to show you guys real quick though is, because I don't have a lot of time, is one that we use a lot with multiple pressure ulcers. It is called Opticell AG. Most of our products use AG because AG is good with fighting bacteria. And I don't know if you can see this, but it's a strip that turns into a gel that is very effective in wound healing. But I just wanted to be able to show you that, and thank you for your time. Go ahead, Diankah.
Okay, hello everyone. My name is Diankah. I am a physical therapist, and I will be talking some more about skin integrity, wound care, and treatment, picking up where Nicole left off. So as of now, I'm sure you've learned a lot about how to identify, grade, provide medical treatment of pressure ulcers and wounds. At some point in our lives, we may experience a wound ourselves, have a pressure ulcer, have a loved one a pressure ulcer, or have to treat a wound. Wounds in healthcare have a huge emotional, economic, and financial burden on the patient. The risk of developing a wound not only increases with immobility, but also as we age, as we develop comorbidities, such as diabetes, obesity, and even post-surgically. According to Advances in Wound Care Journal, a 2018 retrospective analysis of Medicare beneficiaries identified that approximately 8.2 million people had wounds with or without infections. Medicare costs estimates for acute and chronic wound treatments range from $28.1 billion to $96.8 billion. The highest expenses were for surgical wounds, followed by diabetic foot ulcers, with a higher trend towards costs associated with outpatient wound care compared to inpatient. From an economic point of view, the annual wound care products market is expected to reach $15 to $22 billion by 2024. Increasing costs of healthcare and aging population, recognition of difficult to treat infection threats, and continued threat of diabetes and obesity worldwide make chronic wounds a substantial clinical, social, and economic challenge. To stress how much wounds are a healthcare issue, chronic wounds are seen mostly in the elderly population, but not limited to. In the United States, 3% of the population older than 65 years of age have open wounds. It was estimated at the time of this evaluation that by 2020, the US government estimated that the elderly population would be over 55 million, suggesting that chronic wounds will continue to be an increasingly persistent problem in this population. The 2020 projected number wasn't that off, as we are currently at 54.1 million elderly Americans. Pressure ulcer care is expensive and costs more than $11 billion annually in the United States, as per the Agency for Healthcare Research and Quality Statistics. The cost of individual patient care ranges from $20,900 to $151,700 per pressure ulcer, apart from hospital costs, food charges for food, transportation, maintenance, which can give you an additional $43,000. Elderly patients with stroke, diabetes, dementia, and those with impaired, limited mobility or sensation are extremely vulnerable to pressure ulcers. As mentioned by Nicole, pressure ulcers are a localized injury to the skin, underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. This type of wound often occurs in people who are not mobile. These wounds can also occur due to medical equipment such as splints, braces, tubing, poor support surfaces. In the United States, around 2.5 million people develop pressure ulcers annually. Diabetic wounds, also known as foot ulcers. People who have diabetes have decreased sensation in their feet, extremities, which can lead to wounds. These wounds may be at the bottom of their feet, their toes, their ankles, bony prominences, and can be from shoes that don't fit well, friction, or stepping on an object without realizing it. How can you identify and minimize the risk of ulcers and wounds? Well, one approach is to use a Braden scale. A Braden scale can be used to determine the risk of developing a pressure ulcer. It identifies people who are at risk, as well as determining the degree of risk of developing a pressure ulcer. Persons that are appropriate for a Braden scale score are those who are non-mobile and require extensive assist for bed mobility, such as rolling side to side, requires max assist for transfers, use a transfer device. They may also be able to ambulate, unable to stand, unable to reposition independently. Those people who have frequent hospitalizations for extended periods, and as these people who are more prone to skin breakdown. The Braden scale is a scale made up of 6 sections, which measures the risks that contribute to either higher intensity and duration of pressure or a lower tissue tolerance of pressure. These 6 elements are sensory perception, which is the ability of the person to respond meaningfully to pressure-related discomfort. Are they able to feel pain, discomfort, sharp edges, pressure points? Moisture, the degree to which the person's skin is exposed to moisture, such as does the person wear diapers? Do they soil themselves often? How often is this person changed? Activity, degree of physical activity. Can the person move? Can the person weight bear? Do they use a wheelchair for mobility? How much time is spent in the wheelchair? Mobility, the ability to change and control your body position. Can the person move their extremities? Can they reposition weight-bearing surfaces of the body? Can they roll? Transfer from supine to sitting, sit to stand? Nutrition. Do they have a usual food intake pattern? Meaning, does the person eat well? Eats adequate protein? Are they tube-fed? Do they require supplements? Friction and shear. Does the person slide down in the bed or the chair? Do they require assistance? Does this person have spasticity, contractures, agitation that leads to friction? How much assistance is required to move? Are they able to weight shift independently? So each section is rated from a scale of 1 to 4, with 1 being severe impairment, 4 being no impairment. The lowest score you can get is less than or equal to a 9. The highest score is equal to 23. As per Braden score scale, a severe risk is a total score of less than 9 or less. A high risk is a total score of 10 to 12. A moderate risk is a score of 13 to 14. And a mild risk is a score of 15 to 18. The lower the number, the higher the risk of developing a pressure ulcer. Ideally, a Braden score scale should be done on every non-mobile person and persons with decreased mobility or frequent hospitalizations, particularly those who are hospitalized for longer periods, to determine the risk of developing a pressure ulcer. For best practice, it is recommended a score of 18 or higher. You reassess semi-annually and with a change in medical condition as needed. For a score of 17 and below, you reassess quarterly and as needed. A prevention protocol should be implemented involving a multidisciplinary approach. Consider a reassessment after every hospitalization, particularly long hospitalization periods, or if this person has a history of breakdown or demonstrates a risk of breakdown. This is an example of a Braden scale. You would fill out the patient's name, the evaluator's name, the date of the assessment, and then provide a total score. It is already broken down into quarterly sections, so you can complete every 3 months or as needed. You would follow the form as the patient presents with a 1 to 4, and then once you get a total score, you will determine the next step and the plan. So prevention is key, as we said before. Persons with a 17 and below, you want to implement a prevention protocol. These people are candidates for alternate positioning programs. Their seating should be evaluated. They may need pressure mapping. Is this person mobile? Can they effectively weight shift, provide pressure relief? A multidisciplinary approach should be considered involving all the team members. So in the words of Dr. Maribeth Belbin, the renowned management theorist, a team is not a bunch of people with job titles, but a congregation of individuals, each of whom has a role that is understood by other members. Successful treatment of a wound requires the assessment of the entire person and not just the wound. The multidisciplinary team approach is vital for effective wound care. The members of a team should include, but definitely not limited to, the physician, who will provide the treatment orders, the history and physical of the patient, the nurse, as described by Nicole in full detail, coordinate and inform the other team members, implementation of a wound care protocol, monitor lab values, keep documentation, carry out skincare, treatment orders. Rehab, PT and OT will perform an assessment of the patient's positioning needs, provide pressure reduction devices, cushions, mattresses, gel pad overlays, maybe provide pressure mapping support surfaces, train staff on how to use these, and implement an alternate positioning program. The speech therapist may perform a swallow status and recommend a diet consistency. The residential coordinator, if you're in a residence, will monitor the direct care staff and provide re-in-servicing in positioning and the use of pressure relieving devices, report any information or updates to the nurse, PT, OT, and speech. Dietary, nutritional assessment including food intake, monitor the weight and lab values, provide nutritional supplements as needed. Direct care support professional, again, if you're in a residence, they will report on the individual's nutritional intake and any changes in skin integrity. They're performing daily the adult diaper undergarment change. With ongoing wound care education to the residential direct care team, the caregivers can detect wounds and skin breakdown more efficiently, leading to hopefully addressing the skin breakdown as early as possible and maximizing quality care and optimal skin integrity. So just to talk a little bit more about what the physical therapy assessment will include, it would include a assessment of the wound area, range of motion, the mobility, the strength, bed mobility, can this person move their extremities, transfers, can this person transfer, sit to stand, supine to sit, sitting balance, can they sit independently without falling over, stand balance, can they stand, are they at risk for falls, gait ability, can they walk. Based on the results of the evaluation, the treatment may include strength and mobility exercises to improve strength and movement with exercises. In many cases, wounds are accompanied by weakness and decreased ability to move. Addressing deficits with a well-rounded therapeutic exercise and activity program may help speed up the healing process. Physical therapists are trained in wound care and can remove dead tissue from a wound. Other treatments can include the use of specialized ultrasound or electric stimulation, repositioning programs. Physical therapists will train the staff how to transfer a person, how to move them, maybe do a home or a equipment assessment, and also provide recommendations for improvement to seating, bedding, and footwear. So it's important to consider what type of equipment does a patient already have. Do they have a regular bed and a regular mattress? Do they have a hospital bed? Is it a high-low bed or a semi-electric bed? A semi-electric bed is a bed that has head and foot controls. High-low bed has head and foot controls, as well as the bed can lower all the way to the floor, sometimes as low as 6 inches from the floor. With active breakdown and risk of breakdown, the support surfaces should be pressure relieving. What type of wheelchair does this person have? Do they have a wheelchair cushion? What type of bathroom equipment? Do they have a raised toilet seat? Do they have a shower chair? Is any of this padded? What type of transfer devices do you use? Do you use a drawer sheet, a Hoyer lift? What type of sling do you use? Is it a full body sling that stays under you all day? Or is it a removable sling? Do you use a sit-to-stand lift? This just gives you a little bit of an example of the different types of mattresses that are available. Once the physical therapist does the assessment, then they'll make a recommendation for what's most appropriate. The first one is the foam mattress, which provides comfortable pressure redistribution, allows air to flow, and a cool sleep surface. They're usually high resiliency, a soft foam heel area, softer than the mattress body to protect the heel, and it's best for persons with history or identified risk of breakdown. The air pad overlay has air cells that alternate in inflation to allow constant redistribution of pressure, so the alternating cells inflate. They're designed for stage 1 to 2, used for prevention and treatment, used at all times the person is in bed, and these are very cost effective. A low air loss mattress has air cells that run horizontally, or they can run vertically, and inflate and deflate in alteration to allow a constant redistribution of pressure. They're used for persons with active breakdown in conjunction with wound care techniques, best when used on a hospital bed, and may even be used permanently when the wound heals and as a preventative measure. These are more costly than the other two that I just described. Wheelchairs. For persons experiencing skin breakdown and using a wheelchair, the type of wheelchair can have a significant impact on their healing and their wound care journey. Some common types of wheelchair you may have experienced already include a travel chair, which is usually the first basic chair that someone has, also known as a transport chair. It's lightweight, it's foldable, very cost effective, can be used for persons who can walk indoors but need assistance for longer distances due to limited endurance or standability, falls risk. Standard wheelchairs are basic wheelchairs that are more sturdy and can be used with long-term with decreased mobility. Persons using these chairs may need extra support, spend more time in their wheelchair. They may be able to transfer independently or with assist. This chair has features that includes an elevating leg rest, seat belts, they can accommodate wheelchair cushions. The person may be able to self-propel or may be pushed. Tilt and space wheelchairs. They're custom built for the patient, and then you have power wheelchairs, which are also custom built for the patient and the person can drive. So wheelchair cushions are really important. Some that you may come across can include the basic foam, the high density foam, and the air cell cushions. As a side note, please never ever use a donut ring cushion on someone with breakdown in the gluteal area, as this only puts pressure on the surrounding bony prominences and is not effective in any way at all. As we're not in person, and I wanted to show you what these cushions look like so you really have an idea of how to use them, I made a short video. Please enjoy. Hello, I wanted to talk a little bit more about the different types of cushions that were available. These are 3 examples of basic foam cushions that you may see on a standard wheelchair. They are inexpensive, they provide comfort, and they are preventative. These cushions are sponge-like and usually vary in differences in density. This is the foam cushion we were previously talking about. Now we're going to move on to high density cushions. High density cushions are generally used on customized wheelchairs, which may include a tilt and space wheelchair. They provide more comfort, they are protective, and can be used with skin integrity issues. Generally, persons using these cushions are spending most of their time in their wheelchair and may require assistance with repositioning. As you can see, I have to push really hard to even have an indent in these cushions in comparison to my basic foam. Last but not least, we have the air cell fill cushion, which is commonly referred to as a Rojo cushion. These cushions are usually used for people who have active skin breakdown, who are at high risk of breakdown, and they also promote healing. There are many variations of this cushion, one such being the high density foam Rojo combination, your basic version, and this is what it looks like once it's in a cover. To test this cushion, you would put your hand open and push down. Once you have a 1/2 inch give, that's when you know it's appropriately inflated. Your physical therapist or your occupational therapist will be responsible for putting this together. The staff will monitor it. These are the valves that the air is inflated via. So we're going to talk about pressure mapping now. Pressure mapping is another really useful tool when treating wounds. It allows a visual representation of the pressure our body exerts on sitting surfaces. It's a useful computerized tool for assessing pressure distribution when identifying seating or bedding needs, identifying the parts of the body that exerts the most pressure. It uses a pressure pad as well as a pressure mapping system. The peak pressure points are usually the highest pressure over the smallest contact area, usually your bony prominences such as your ischial tuberosity, your coccyx, your sacrum, your scapula, your occiput, and your heels. I have another video to show you, as I think this is an important part to understand of how much pressure our body really exerts on surfaces that you as a normal person sits, and if you have someone who is experiencing this pressure but they can't verbalize that to you, this system just helps that all the more understanding and easy. Next, we're going to be talking about the pressure mapping system. This is a pressure mapping pad and basically allows a live feed of the amount of pressure your body exerts on sitting surfaces. Ideally, when you sit on this surface, if you refer to our map over here, you want the amount of pressure your body exerts to be between blue to green. Anything in yellow, red, orange, etc., it's considered very high pressure, and you'd want to tweak your sitting surfaces to make sure that you stay in the blue or green area. So I'm going to place my pressure pad on this chair. Next, I'm going to sit on the pad so you can have an idea of how much pressure my body exerts on this pad. As you can see, the red to yellow indicates higher points of pressures. Some things to note here: my feet are not flat on the floor, they're actually kind of dangling, and I can feel as I'm sitting lots of pressure right under my ischial tuberosities as I'm sitting, my right greater than my left. This is also a very hard surface. We're now going to try a basic foam cushion along with my pressure mapping system to see how much pressure relief I can get from this cushion. And as you can see, I'm sitting upright. I've eliminated my reds for the most part, and my feet are still dangling. And I am getting some pressure from this cushion. Ideally, we still need to keep looking because there is still some yellows and some reds in this cushion. Next, we have our high density foam cushion in our tilting space wheelchair. I'm going to sit on it again so you can see the differences in pressure. So right now I have pretty good weight bearing on this chair. I have lots of blues, which is what we want, and there's no yellow, there's no orange, there's no red. So this cushion right now is meeting my needs to provide maximum pressure relief. Right now, my tilting space wheelchair is tilted to about 25 degrees, which provides pressure relief. Now let's say I had a hip flexion contracture, meaning I had my leg up like this. As you can see on the screen, I'm putting a lot of pressure right now under my left hip area. This is something to be mindful of when doing pressure mapping, as the differences in your body will affect how much pressure is placed on the seat based on contractures, spasms, inability to maintain postures, and different things like that. Our final cushion is the Air Cells cushion, similar to a Rojo, that can be preventative and can be used for people with active skin breakdown. If you look on my pressure mapping system, There are many spots of blue. There are no spots of yellow, orange, red, which verifies that my pressure is being equally distributed in the most effective manner for my needs at this time. So, moving on, as part of the PT program, it can include an alternate positioning program, which is customizable to the patient. It's based on your equipment available, such as a bed, recliner, wheelchair, shower chair. Repositioning should occur every 2 hours. Offloading is recommended for more progressive wounds. And in severe cases of repeated wounds, stage 3 or greater, you want to consider having a low air loss mattress at all times. This is just an example of a repositioning log that I've created and I use often. It is every 2 hours, 24 hours a day for 7 days a week. The staff would initial the position based on what equipment you have available. They would sign their initials, and you can easily track that this person is being repositioned every 2 hours. For this particular patient, we have a tilt and space wheelchair that can be upright, tilted. We have a hospital bed, right side lying, left side lying on the back. I always include that the patient must be upright during meal times and digestion periods. And you can sometimes, if needed, let's say the person was in bed at 10 a.m. and then they had a shower and went back to bed at 12 p.m. That doesn't mean that you should write bed in bed for 10 and 12, because that would indicate to a reviewer that you were in the bed for 4 hours. I've asked staff to sometimes write 2 positions in one slot, indicating to a reviewer that they did in fact change positions within that 4-hour period. Just wanted to talk about some alternative adjunct therapies that may be available. You can have hydrotherapy, which uses a whirlpool to decrease swelling, control inflammation, promote wound healing. We can have ultrasound, which delivers a high-frequency mechanical vibration from high-frequency sound waves to facilitate healing at a cellular level. It can reduce pain, increase circulation, increase mobility of soft tissues, and promote healing of injuries and wounds. Electric stimulation is another mobility that can be used by therapists. There are various forms of e-stim. E-stim has the ability to restart and accelerate the repair process by imitating the natural electric current within the injured tissue. E-stim has been suggested to reduce infection, improve cellular immunity, increase perfusion, and accelerate wound healing. The National Pressure Ulcer Advisory Panel continues to support e-stim as a useful therapy for non-healing wounds, such as the recalcitrant, uncooperative stage 2, 3, and 4 ulcers. If you are a person who enjoys celebrating special days of the month, then there's a day for you for this month. It is the Worldwide Pressure Injury Prevention Day to bring attention to pressure wounds, and this year it will be on November 18th, so go out and celebrate. In conclusion, I've included some humor here, but as we all know, time does not heal all wounds. I thank you for your time and your attention to this issue. It is my hope that you can use some of the information that Nicole and I provided to you to deal with your next wound or your next scenario, and hopefully it helps. Thank you. If there are any questions, we'd be happy to take them.
Thank you so much, Diankah. Nicole, wonderful presentation. So we'll get to the questions. So the first question is, do you at St. Margaret's use any skin risk assessment tools periodically for the children in your facility to drive your prevention efforts?
We actually, since we're governed by New York State Department of Health, we are required to utilize the Braden scale. We do those quarterly, annually, on admission, readmission, and when a new pressure ulcer is found. However, I will tell you that regardless what the score is on the Braden score, we care plan all of our kids as high risk for pressure. We do not have very mobile residents in our facility, and our base of treatment is based on the fact that every resident that walks in our facility is high risk, regardless of their Braden scale.
Another question is, how do you debride without causing pain to the person?
Well, with a wound, for the most part, once you get past the first layer, that top layer of skin, The nerves, where the nerve endings are contained, there really isn't any pain in the wound bed itself. So the debriding process in the wound bed is not painful. However, what you have to be careful of is the edges of the wound, because there are still nerve endings there. But for the most part, I've never had issues with pain as far as debriding a wound.
Thank you. Do you find there's good inter-rater reliability when using the Braden scale?
We use it as a scanning tool, ideally, at our residences, as someone develop to identify the risk of developing a pressure ulcer. So yes, in my practice, I have found it to be effective, as the nurse will is often at the residence, not the therapist. They will do a scale based on whatever findings they may have or changes in the patient. Then the therapist gets involved and activates the protocol. Whereas if we didn't have the scale, we would not know that it was something that was necessary. So nothing would have probably happened in that sense until there was an active breakdown.
Okay, thank you. And how expensive is pressure mapping technology?
So the technology that we have, I inherited it from other people that were already here. So I would imagine it's a little bit more costly now, as our system is a little bit older. And there are lots of websites that offer price quotes for it, depending on what you need, and depending how detailed you want to be in your pressure mapping, because you can go very minimal or you can go very in depth.
Are there any other questions? We've got about 5 minutes left. No?
I would just like to say, as the medical director of St. Margaret's, I really applaud Nicole. She developed this whole plan with our goal of not delaying intervention, for the 48 hours between doctor visits, so that we have this protocol where the appropriate treatment can be started as soon as the wound is noted. And we're hoping to see that over time we see less progression to deeper wounds by getting to them right away. So good job, Nicole.
Thank you, Dr. Kansas. What I will say is, prior to us initiating our protocol and our guidelines, the first year that we started them, before the training went through, we had 9 wounds that were in our facility over the year that were greater than a stage 3. And the following year, once our protocol and guidelines were implemented, we had none.
That's great. All right. Well, I think we'll finish a few minutes early. Thank you so much, Nicole, Diankah. Wonderful presentation.
Welcome.
Thank you.
So I think we are at the end of our conference. So Deb, did you want to post the post-test and evaluation links?
I just put them up, Vincent.
You did?
Yep.
Okay, great. So I want to thank you to all of the speakers and the wonderful presentations. It was great. It's been a long time since we had this, and we're hoping that we can see all of you next year on November 4th, when we hopefully will have this same conference on site in Saratoga. Before we break, I do want to give a huge shout out and thank you to Deb Williams, who is really the engine, boots on the ground, ringleader, just runs the show. And just thank you so much for organizing this conference, Deb. And I'll give about 6-7 minutes left to everyone to enjoy the rest of the afternoon. And thank you so much for attending this conference, and take care.
Someone said they can't see the post link. I put it in there. Do people see it?
I'm not seeing it, Deb.
You don't see it.
Oh, I wonder, I probably just sent it all to Bill. Hold on a second.
Bill, you got to share the love.
Guys. Because I was chatting with him. Here we go.